I will try to summarize as much as I can.
Yeah, please, in 10
So,
minutes. Okay.
okay,
Okay,
okay.
please.
So
Yeah.
let's see the perspectives of the doctors, the patients, and what's going on in the prevention and treatment guidelines in gynecology. And I'm so proud to present you the largest survey of Europe that captures the views, the fears, and perspectives of the patients. So you all know the effect of COVID pandemic on the prevention. We know that this is the latest meta-analysis, CIM1, 2, and 3 pre-invasive lesions. A great majority of these lesions do not have a progression rates, so you can easily follow up all of these cases during the pandemic period. The great majority can be actually postponed. The real effect of the COVID will be seen after the first wave and the second wave. We will definitely face a post-COVID tsunami as we see in different countries. There will be also some economical crisis. The research fundings will be limited, and the money will be usually forwarded to the treatments rather than the prevention. And of course, it will definitely have some effect on WHO cervical cancer elimination program. So from the prevention side, what is suggested is actually just to define a new referral threshold. So these are which patients are referred to colposcopy and screening. And different countries use different thresholds. Usually this is 20% in Europe, 5% in the latest American guidelines. On the left part, you see the latest American guidelines, and you evaluate the patients in a risk stratified manner, the HPV vaccination status, the age, the previous screening status, and you define a CIN3 risks. If it is more than 5%, then you recommend a colposcopy. Now, during the COVID, of course, based on the situation in your country, the patient numbers and the COVID waves, you can, update your referral threshold to 10 or 20 or even 30 to 40%, depends on the country. This is the latest screening program of Norway. You can see that in Europe, usually we use 20% for CIN3 risks. The pre-test and post-test risks, you see, this is HPV positive lady. And if you do the reflex cytology, which is negative, then you can easily make the risk download, or if it's positive, then the risk may be rise to up to 50%, and which makes really sense in the COVID that you can refer. So the basic message is that you should define your own colposcopy referral rates. There are different societies. If you look to the guidelines, American College of Surgeons, American Society of Cervical Pathology and Colposcopy, British Society, SGO and ASGO. And basically, these documents will be found in the Congress attachments, as we discussed previously with Alex. But what is the idea that if you are really suspicious of cancer, you should really refer the patients to colposcopy in weeks. This is usually 2 to 3 weeks. The second point, that if the patient has a low-grade disease, a high-grade disease, then you should make the management within 3 months. And if the patient has a low-grade disease, then you can postpone the procedure for diagnosis until 6 months. This is our latest publication. A group of European experts from ESGO and EFC has come up during the COVID period, and we published a recommendation on vaccine, screening, and treatment. So vaccine is already discussed today. We suggest additional recall on awareness strategies in the post-COVID period, and to complete the vaccination schedule within 12 to 15 months from the first dose. For screening, of course, in many countries, the suspension period will make the list of the people who's waiting for the feature screening. So please make an accurate list of women who were postponed and start your virtual consultation. Please produce comment statements from the National Society's web pages and try to use HPV self-helping and even telecolposcopy or digital colposcopy technologies. One of the highly asked questions from the gynecologists in Europe was that what will we do with the HPV positive patients? As you see from these two trials, the risk for CIN3 for HPV positive patients is between 16 to 30%. So the suggestion is that for these patients, you should, during the pandemic, continue with a reflex cytology and define a new threshold for the lady, because if there's reflexology is ask-age or high CL, then the CIN3 risk is around 40%, which needs an immediate colposcopy within 2 to 3 weeks. So these are the suggestions for screening and for treatment of pre-invasive disease, colposcopy in treatment. And as I told you, we have 3 groups. This is the invasive cancer risk, which you are really suspicious. It should be done within weeks, 2 to 3 weeks. These are the high-grade lesions, including cervix, vagina, and vulva. We suggest to finish the diagnosis within 3 months. And for all the low-grade lesions, such as low seal, ascus, and something like that in vagina, vulva, and cervix, you can postpone the procedure in up to 6 to 12 months. So these are the pre-invasive diseases, but actually in invasive carcinoma, the guidelines really changed a lot, because it was particular for surgery. These 2 very important study was very cornerstone for us. As you see, asymptomatic, just COVID positive patients. The first report came from China. In cancer surgery, the mortality rate postoperatively was around 20%. Then I was also included in the surgery, the Birmingham study that's published in Lancet, so-called COVID surge cancer trial. And again, in the general surgery operations and gynecology operations, we reported a post-operative mortality around 25%. So these are very, very high numbers. And accordingly, the guidelines has been updated in the treatment of invasive carcinoma. We did less radical surgery. We did more chemotherapy and gained time for preparation for a radical surgery. And for chemotherapy, if possible, we use more oral forms of chemotherapy rather than hospitalization and IV forms. There was no problem within the radiotherapy, but giving the radiotherapy in a more fractionized, more divided doses was commonly used in Europe. And the main idea was the less hospitalization, less hospital visit, more telemed consultations. The changes of these guidelines, of course, had some effects on the cancer. All these changes in the guidelines came from the national societies, scientific societies, doctors, the medical staff, the media, television, and of course the governments. But nobody actually care about what is the idea, what is the perspective of the cancer patients. All these inputs had an effect on the cancer patient's psychology and their trust on the treatment. And we from the ESGO point, we believe that the patient voice should really be expressed and presented in a public forum. Accordingly, we did a very nice survey, and now we see that in many governments, the patients are represented before the COVID measures, legislations. Actually, the governments started to listen what the patient's idea is. And the first example came from Netherlands. For all COVID measures, now they also listen to cancer patients. So this study was a prospective survey study, and all gynecology patients was included. We divided the patients into 3. Type 1 was scheduled for surgery, type 2 was scheduled for chemo radiotherapy, and type 3 patients were the ones who were actually under routine follow-up. And these are the sections of the survey: the demography, the perspectives and experiences against COVID, very professionally translated anxiety and depression score, HAT scores, which the score above 11 showed severe anxiety and depression. So these are the countries that have contributed to the survey, and as you can see, the East to West, to North to South, and Central Europe was homogeneously representing the whole Europe within the survey. And as you can see here, very strange, very important, a great majority of the patients, 70%, were afraid because they believed that cancer patients had a high risk for COVID infection. However, if you ask to the patients, are you afraid of cancer or COVID? The great majority was afraid of their cancer, not the COVID. Only 17% was afraid of having a COVID infection when they go to hospital for their treatment or follow-up. It is very strange. And actually, 71% was really concerned about the progression of their disease if their treatment or follow-up was canceled or postponed. And we actually did a sub-analysis. Who was afraid of COVID? Not the cancer, and this 17%, which is a small minority, are failing of COVID, and the only factor that was causing this concern was the age. So we believe that we did a lot of measures on the elderly patients, and it produced a great concern of COVID compared to cancer. However, in young patients, COVID was not a concern, but the cancer follow-up and treatment was a concern. This number is very important, a European number. In 64 cases, regular and routine treatment was done. So in 35% it was changed. And in this 35, only 7% was changed because of the desire of the patient. So in a great majority, postponement of the treatment was done by the decision of the doctors. This is the European map that we have created, and as maybe expected, the Nordic countries are very happy during the COVID period. The cancer patients in Nordic countries, in Denmark, Finland, had very low scores. But in Italy, Poland, Turkey, Greece, the Czech Republic, the anxiety and depression scores was really high, and in severe anxiety and depression scores. If you look to the European anxiety score of the patients, the only factor that increased this anxiety was their concern about not being able to visit the oncology doctor. And this was the same also for depression. If you evaluate the multivariate analysis for the depressed people, again, the only factor, the odds ratio is around 9, was their concern about not being able to visit their doctor during the COVID pandemic. So this, the largest European survey gives us some clues in the secret window of the patients that the cancer patients are really concerned for being abandoned from their treatment teams. And what is our take-home message for the second wave? Even in the times of crisis such as this pandemic, everybody should really sustain the oncology services, prevention, screening, diagnosis, and treatment as much as possible. Of course, we similarly, at the same time, with the doctor's perspective, as going off survey. This is done by charity, by Jalit. The patient survey was conducted by me. So, you know, the main message of this doctor survey was that this is the previous time that all doctors were working for one patient, but during COVID, it was not possible, and one doctor was responsible maybe for 4 to 5 patients. This is the doctor survey, and similarly, we ask the clinical infrastructure, trial participation, maintenance therapy, and the management. And the most striking results that I want to share with you is the surgery. Definitely, the curative surgery has been dropped to 60%, the same number that in the patient survey we've seen. A great majority of the surgeries done is the palliative or emergency cases. So in the cancer cases, there was an overall minimal 10% reduction in the cancer surgeries. And for many cases, the surgery date was postponed at least 2 weeks, in some countries up to 3 months. And both in ovarian, endometrial, and cervical carcinoma, despite the fact that the classical treatment is surgery in a great majority of these cancers, especially ovarian cancer, more proportion of the patients has been treated with chemotherapy rather than surgery. What happened to the clinical trials during the COVID period? The ongoing trials continued in only 45%. So in more than 50%, the trials are canceled. And the main reason was the cancellation due to the hospital management. Sometimes it was the reason sponsor, sometimes the resources, and sometimes the patients. But in half of the cases, the clinical trials on cancer has been stopped during the COVID period. As I told you, there was no big difference for the radiation therapy. It was only 16% that they postponed in Europe the radiation therapy, but the great majority has used specified low dose and divided fractionated radiotherapy during the COVID period. In Europe, telephone and video conference was the most commonly used information and communication channels between the doctors and the patients. So in summary, the doctors had more tendency to treat with chemotherapy rather than surgery. which had a longer waiting times for the curative surgeries. There was a huge difficulty in providing medical care due to the staff shortage, and they represent the concerns regarding how to triage and prioritize the cancer patients. Ultimately, at the end, what I can say that we are smart people, and we cannot change the cards that we have in our hands, but we need to change the table. So what it means that based on the COVID situation and seeing the perspectives of the patients against these guidelines, we really see that there is a big need for communication between the doctors and patients. And we should, in the second way, focus on that. The patients want to understand why they are postponed and what will be the next. Thank you very much, dear friends.